Hi, I'm Leslie Randall. I am a GYN oncologist at the Virginia Commonwealth University, and I am the cervical cancer lead clinical trial advisor for the GOG Partners Group. And I am here with one of our absolute superstars, Dr. Linda Duska from my neighbor, University of Virginia in Charlottesville. Hi, Dr. Duska.
Hi.
Hi. Tell me, you wear so many hats there at UVA. Tell us what you do there.
I wear a few too many hats. I would agree with you there. So like you, I'm a GYN oncologist. I still practice. I operate and see patients. I run our clinical research program for GYN oncology. But about 6 years ago, I moved a little bit, 50% into the dean's office, and I run, I'm the associate dean for clinical research for the School of Medicine, which means I have the opportunity to really build research infrastructure for the entire school and not just for cancer. So that's really, really fun. And as of March, I became the interim senior associate dean for research for the school, which is a huge job that I'm still actively learning.
Wow. So, I mean, this is a great perspective because I don't know that we have anyone, you sit on our investigator council and the GOG partners. I'm not sure that we have someone who has this type of, pathway trajectory and has this type of experience that you have. So really great. It's really great to talk to you today. Thanks. So I have to tell you, we're doing this series on just talking about how we make our sites better at, everything that we do, getting our studies selected, getting them open, getting them accrued, getting the, data in a quality way. So we're doing this series of videos. And the reason that we wanted to bring you on is because a couple of things. First of all, you've built a really great program and you've led that through, the whole from beginning to where you are now. And the second reason is your accrual track record is really outstanding. Really outstanding. And we have some trials where you have, half of the accrual. And particularly, I think in cervical cancer, which is my world, I think that you're particularly a superstar in cervical cancer, but you guys accrue well to all of the trials. So we're here, we want to help new sites get started, and we want to help our established sites become great sites. So I think that you have the unique experience of sort of having both. You've had your foot in both parts of that continuum. So I'm just really curious. We would love to pick your brain to get started. If you could talk about, remember back to the time when you were just getting started in your research program, and, tell me the top 3 things that you had to focus your efforts on in order to get going.
Sure, happy to do that. So first of all, I didn't build this program by myself. I have to give a lot of credit to the people who came before me and who also work with me now. So I've been at UVA for 13 years, but before I got here, Dr. Laurel Rice, who we all know and love, was here and really built with Dr. Susan Modisette, who is our NRG PI, a tremendously strong GOG portfolio. And GOG back then, UVA was a main member of GOG without any affiliates and made their points easily. Wow. So that happened long before I got here, and they really built the foundation for me. So I came in on very strong shoulders, and I really need to give them credit. And then the other people I have to give credit to are my current partners, because they, if the people that you work with and that you see patients with really need to also, I'm going to use this term because it just gives you a visual of what I mean. They have to drink the clinical research Kool-Aid, so to speak. Mm-hmm. Everybody has to agree that clinical research is really good for our patients. And also, of course, for our cancer center. So we have a NCI designated clinical cancer center, like you do also. And it's good for our cancer center for us to accrue patients. So it's good but primarily it's good for our patients. And my partners, Charles Landon, Lee Cantrell, Susan Modisette, Kari Ring, and I have all believe very strongly that clinical research is important for our cancer patients. So couldn't do it without them. So I have to say that first. So one of the, you asked me for three things. So I think the first thing I would say is that, and this is when I talk to other groups around the school about how to choose studies to open and how to build a program, the word that I use the most is feasibility. And feasibility is a word that you can use in multiple contexts. But in this context, I primarily mean, don't open a study that you can't accrue to. That is really dumb, and it's a waste of everybody's time and energy and the resources in your school, right? I had one investigator come to me and say, I got this study and it's so great, and I opened this study and I'm so happy, and what are you going to do to get me patients for this study? And the patients that she wanted were a very particular group of people that simply do not live in Charlottesville, Virginia, or in Central Virginia at all. Her study wasn't feasible, right? And to your point about cervix cancer, there are so many women, unfortunately, in the part of Virginia where we live that have locally advanced and recurrent cervical cancer. That cervical cancer here, it's easy to accrue to cervix cancer trials. And so, so what I would say, the first thing is that you need to open studies that you know you can accrue to, and that your partners agree with, because if your partner says, I will not put my patients on that trial because I don't agree with that treatment regimen, there's no point in opening the trial, you won't accrue to it. So that would be my first piece of advice, is really look at feasibility. The second thing that has worked really well for us is diversifying our portfolio. So we went from being majority GOG trials to having a more diverse portfolio. And what do I mean by that? We have NRG trials, certainly. We have ETCTN trials also. We're a subsite of Hopkins for ETCTN. And I do believe that it's really important for us to contribute patients to NCI-sponsored trials. That's really important. But you can't run a program only on NCI-sponsored trials because you'll go bankrupt. I mean, that's just how it is. So, and I also feel it's really important, particularly for investigators, to have an investigator-initiated portion of your portfolio. So when I look at my portfolio, I want to make sure I have a really good balance of NCI-sponsored trials, pharma trials, GOG Foundation trials, and investigator-initiated studies, so that I have a wide range of opportunities to offer patients, but so that everybody can feel like they have skin in the game, in a sense. And then I had the last thing in my head and it just went away. Oh, I think David O'Malley talks about this a little bit. You need to have, you don't want to have too many trials for the same patient population. In large part, and platinum-resistant ovarian cancer is a great example. If you have 8 studies in platinum-resistant ovarian cancer, unless you do what David did, which was really great, and prioritize them for your clinical research staff and your patients, you're going to be presenting your patients with too many confusing options. Your providers are going to have too many confusing options, and it's going to be easier for everybody to just do standard of care. So we have, we're very mindful of what studies we open. We don't open competing trials because that will really limit your ability to accrue well. And I make sure that my queues are full, but not over full, because if your queues are over full, again, you don't want to open a study and put just one patient on. You want to open a study, you want to tell that company or your, we call it a PRC or SRC, whatever, I'm going to put 5 patients on a year, and then you want to meet your accrual goal. You don't want to open a study and never accrue or not meet your accrual goal because you have too many studies open in the same group. So, and then you asked me for 3 things, but the last thing I would say is my team, in addition to the 5 attendings in the team, I have 4 clinical research coordinators and 2 regulatory people. And in particular, my clinical research coordinators are a big part of helping to decide what studies we open and what studies we don't. And they need to drink the Kool-Aid too, and to do that, they need to be part of the decision process. And my clinical research coordinators get very excited about a study, come to me and say, I really want to do this study. And if it's feasible and if we can do it, then they're part of that decision process. And I think that really helps if you have a team. your entire team that really buys in.
Those are great. Those are such great points. Those are such great points. I think, for feasibility and really your queuing, how you queue up your studies and strategize your portfolio, to me, those are sort of linked. And it's so tempting to want to open trials. When I came to VCU as a new person, like I wanted to open the trials, and I thought, okay, as long as we get these trials open, we can get patients on trials. We still have some practice building, to do, which we're doing, and that's happening. But feasibility, so important, obviously. And, for your portfolio comment that you made, I think, part of what we try to do with partners is really bring these industry options to our centers, both academic and community, and do so in a way that makes sense for our patients, so that a GYN oncology or medical GYN oncologist has helped design that trial, has been a part of that trial. You're leading one of our our chemoradiation with pembrolizumab study. Like, we have a G1 oncologist as the PI of that study. And if, like, for example, for your GOG 3047 study, we're collaborating with NGOT. They're the lead group. We have a smaller portion of the enrollment, but we have you as the leader of that enrollment here in the US. And so this is so dramatically different than the way we've done trials in the past. And I think this is continuing to evolve, and we're still trying to educate ourselves and our group about, what's this, how are we doing this? And so, it's our hope that the industry part of your portfolio is GOG partners.
Oh, of course, yes, thank you.
And I think for yours, and I know your portfolio because you're so, our groups are so great, and we collaborate so well, and you share. We have our journal club, and you share your portfolio with us every month. And so I know that's true.
Thank you for making that point. It can be really, I should have made that point more clearly. I'm sorry. It's sometimes, especially when you're just building a portfolio, it can be very hard to make those inroads in with pharma. And when pharma reaches out to you to do a study, to your point, you have no idea how important that is to our patient population, who designed that trial, who's running that trial, et cetera. So GOG Foundation gives folks who are building a clinical trial program the perfect opportunity to have access to these pharma trials, because it's really what it is, but really quality pharma trials that have been vetted by the experts at the GOG Foundation, like yourself, for example. And so it's a really incredible way to build I'm going to call it the GOG Foundation part of your portfolio / pharma, because GOG Foundation is really being the segue between the investigator and pharma in a way that's incredibly valuable, to your point. Also, to your point, and I should have been more clear, most of my pharma trials are phase 1. We have a pretty robust phase 1 program. So you'll let me know when GOG Foundation
is true.
Phase 1. But most of the phase 1 studies that we're doing right now are being done directly with pharma. And those are very resource heavy. So for somebody who's starting a clinical research program, and you alluded to this when you first spoke, I would open maybe 2 or 3, but no more than that to start with. And and the reason I say that is because, you and I, we see a patient, we put them on a trial, we see them through the treatment, we see that part of it. That's a lot of work. But the people doing all the work behind the scenes, their work never ends. So they're doing all the regulatory work, they're entering all the data into the database, they're sitting with the monitor for 3 days every time a monitor comes in. And not only that, but when the patient comes off, they're reporting all the SAEs, right? But then when the patient comes off trial, there's still tremendous amount of data that needs to be entered into the data. So if you open too much at once and you overwhelm your resources, that can also be a problem of a successful program, right? We've talked about that. And So my advice in building a program would be to start small and make sure everybody understands, particularly the PI, because some PIs just don't understand all of the background work that has to go into all of this, all of the regulatory and data work that we've talked about. And because it's not just putting patients on study, it's making sure that you get accurate data to the sponsor, whoever the sponsor may be, so that they can get an answer about
Mhm.
the toxicity of the therapy, whether the therapy is working. I mean, that's why we do these trials, besides just giving our patients opportunity for treatment, of course. So not to overwhelm your resources too early, because otherwise you're just going to be unsuccessful. That's another piece of feasibility.
So this is a hot button with me because, I think that if not only it goes all the way back to your initial comment, like everybody's got to drink the Kool-Aid.
Mhm.
So, not only do you have to value clinical research, like your institution has to value clinical research. And if they do, then they have to help provide you the resources. I think, this has been a little bit difficult during COVID with people shifting their work-life balance and hiring freezes and all kinds of things. But, hopefully this is all going to get sort of back to a more normal situation soon. I think that it's good that you have enough resources that you can open several trials, so that you can cover that portfolio, you can diversify that portfolio, like you said, which I still think is really important, and be able to support that and not burn out your team. These are the last people that we want to let get burnt out, right? Because their job is really detailed and really hard. And, there's so much room for error when reporting these, SAEs very specifically and entering data very specifically.
To your point about institutional support, I'm very lucky. I have a cancer center that's very supportive. But I will add to that my clinical research program pays for itself. So I pay for all of my support that my cancer centers provided. They charge me for it, and I pay for it out of my clinical research grants that I get from GOG Foundation, as an example. So, and we also, this is going to vary from institution to institution. Of course, if you're not in academic medicine, it'll be different for you as well. But we also charge a little bit of physician salary, very little bit, to our clinical research grants, and that helps us get more departmental support also. But our research program does pay for all of our research support staff.
Yeah, that's great. Maybe the next talk is for you to share how you budget and contract, because we all do it differently. And some do it very much to our advantage, and some do it very much to their disadvantage, and aren't, aware of what what's fair to request. And I think that that's so helpful to institutions.
Yeah, we need to have a budget workshop.
We need to have a budget workshop. I love that idea. Yeah. I love that idea, because that is how you get that's really how you get your institutional buy-in, right? Yep. It's more than just a philosophy. If you can pay for it, even if they don't believe in the philosophy, which hopefully they will, but if you can pay for that, then it's just a no-brainer.
Well, and my institution gets their fair share of F&A on all of this too. Again, academics is a special situation, right? But there's a fair bit of F&A built into all of these contracts. The only other thing that I didn't say, but I'd like to say, is that my goal is to create a situation where every single patient has the opportunity to participate in a clinical trial. Even if it's just a banking trial. We participate with a tissue banking trial with Dr. Maxwell at Innova. And so even if I don't have a trial for you, I might offer you a tissue banking trial. Or, I would love to have a trial open for every single patient. And the other thing I would add to that is that I have been surprised, and I'm probably, you wouldn't be surprised, but people might be surprised that the patients that you think might say no, if you walk in there and you're passionate about it and you say, clinical research is really important to me, this is my passion, I want to make sure you know all your options, here's a trial you're eligible for, that patient might surprise you and say yes. She might not, but she might. And if you have a philosophy with you and your group that you're going to offer every single patient a study, and be okay if they say no, you might be surprised about how often people say yes to you that you thought might not say yes. So
yeah, I think that's probably, it's, such a great point, probably why you've been so successful with Accrual. In terms of Accrual, I am curious, sometimes you have barriers to Accrual that you wouldn't expect to be barriers. I think we all put it on, 10% of adult patients participate in clinical trials. We tend to think that, oh, well, patients don't want to go on clinical trials. And what is the figure? I think 85, 90% of kids go on clinical trials. What's the difference there? I don't think it's all patient. I don't think it's all patient factors. What other factors do you think play a role?
Oh, that's a really good question. On the patient side, I definitely think there's an aspect of trust, particularly for racial and ethnic minorities in Central Virginia, where most of the providers are white. We have that issue of trust, and we have history in Virginia that people still remember. On the provider side, I think that there is also a bias, and we talked about this patient wouldn't want to do this, she has small children, or this patient wouldn't want to do this, she lives 3 hours from here. There's definitely financial toxicity that factors into this. So for instance, if I have a few studies that require a patient come in day 1, day 2, maybe for pharmacokinetic blood draws, maybe that patient can't do that for whatever reason. She doesn't want to pay for parking at my site 2 days in a row because my site charges for parking. She doesn't want to drive 2 hours to get here. So there's definitely a financial toxicity, or she can't take 2 days off of work.
Right.
That may impact their ability to go on a study, or I may not have a study to offer. And if I don't have a robust enough program, and you come to my site, I might not have a study to offer you because I simply don't have a robust enough program. But I also think those are the kind of superficial things that we all think about, but I also think it's probably a lot deeper and more complicated than that. And I'm sure you hear this too. I hear a lot, I don't want to be a guinea pig.
Yeah,
I don't want you experimenting on me. I don't want to be you're just like experimenting on me because there's nothing else you can do for my cancer kind of thing. And so I think, patient education and provider education are critical here. We're doing this for provider education, right? But I think we need to do a better job of patient education. And one really interesting thing that I learned, one of my fellow graduates did a patient education study in urban Philadelphia and found that the education really improved patients' acceptance of clinical research. And then when we repeated that in central rural Virginia, we didn't find the same results. And so I think what that tells me is that you need to target your education at your audience. There can't just be one educational video that you play for a patient who lives in Boston versus rural Central Virginia versus the middle of Wisconsin versus, Alabama. You have to really target your education to your patient population. So I think we're just starting to learn how we can do a better job of a more, not just accruing more, but a more diverse accrual, and how we as providers can do a better job of building trust, educating our patients, educating ourselves about how to do a better job of this. And the trust is a huge thing, especially with what's going on now with the COVID vaccine as an example, and people not believing science and not feeling like they're being experimented on by the government. That is something, clearly there's an underlying attitude in this country that we need to do some more work on, my opinion.
Yeah, I wish, there's so many great things happening as you're part of this progress that's happening for all of our cancers. And just to get, for clinical research to be presented in the light that it really is, like it is the path forward to progress. And And so for me, like to be a part of that progress, like there's just no option not to do that.
Exactly.
And I know you feel exactly the same way.
Yep.
So I think, for me, like we service doctors in our catchment. Like to me, I see myself as a service to, you know, medical oncologists and other G1 oncologists in my area. Because not everyone can create all of this infrastructure that you're talking about, that it takes to support clinical research. Not everyone can create this culture. It takes extra time and extra effort. And so I see myself as a service. You certainly have served a great service to me, because when I don't have a trial, when we don't have one, we just text you and see what you have.
And vice
We're so
versa.
close, and
Well,
vice
so,
versa.
yeah, I mean, I think that's a really good point. So we're an hour and a half apart. We're two NCI designated cancer centers. And we have talked about, this is not a competition. We should have complementary portfolios so that you can send a patient to me, I can send a patient to you. But also to your point, we've got a lot of medical oncologists in Virginia who are giving chemotherapy, who, you know, establishing those referral patterns where somebody might say, I'm going to send Dr. Randall this patient for this study. And then when and if the patient comes off this study, Dr. Randall's going to send this patient back to me. And so I'm giving my patient an opportunity that I'm not losing that patient to VCU. I'm just, you know, that patient will get sent back to me, and establishing those relationships is really, really important. And once you establish those relationships, your phone starts ringing off the hook, because people are calling you and saying, hey, I heard you have this study. Can I send you this patient? Because they know that you'll take good care of their patient, and also that you'll send the patient back. And I think that's really, really important.
No, absolutely. So important. You know, I struggle with, like, how do we, I feel like we could do so much better with accrual and access if we get the word out, you know, to medical oncologists. And I guess because I'm new and I'm just still building these relationships, and I onboarded during COVID, but I think you hit the nail on the head. Like, you've got to establish relationships with your outlying, your referral base, so that they know that, you know, most likely you'll have a trial. Like, if they call you several times and your answer is no, 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 all over and over, they might just say, oh, I'm not going to call again anymore. It's kind of a waste of my time. But, you know, if they call, and like you said, you know, you've got a trial for them, you help it, make it easy for them to access, you keep them informed, you send their patient back. Like, that's ways that we as research clinicians can service our referring providers and try to get these, you know, patients better access.
Well, we can also reach out to the patients, right? So the GOG Foundation is already doing a lot of social media related things, because the other thing we can do, and has worked really well for us, is reach out to the patients, but via whatever format of social media you choose. And then the patient who said, oh my gosh, I saw that this study was being offered at VCU, to her doctor, would you mind referring me? That also is an opportunity to open up the floodgates of referrals in. So that's been a really successful venture that the GOG Foundation is doing to help educate our patients about how important clinical research is and what opportunities there are out there that they can then say to their doctors, hey, I heard Dr. Randall had 3047 open at her site. Can you shoot me over that way? I'd really like to do that. So
that's a great point. That's the next wave, right?
Yep.
To go straight to the patients involved. The patients are more educated and more involved in their care than ever before, I think. And, you know, that's how we get people on trial. That's how we make progress, how we get the trial done. We get the next question answered, and the next question, and the next question.
Yeah, and just as important, we give our patients access to treatments that, I mean, some of the diseases we take care of, recurrent cervix cancer being one of them, are just awful, unspeakably awful. And we're giving patients the opportunity to get something that might be better than the standard of care. And that is just, it's really satisfying to be able to offer patients options when maybe, you know, 5 years ago, we weren't able to offer them options at all. And now we have so many options in endometrial cancer and cervical cancer and in ovary cancer. We have options to offer that give people hope, you know. And so we take care of our jobs are hard. And one of the things that gives me joy, our patients die sometimes. And one of the things that gives me joy is being able to offer somebody who's run out of hope for a possible treatment. I don't promise it's going to work, but I can offer her hope that there might be something new out there that's, going to work for her. So that gives me, that's why I drink the Kool-Aid.
No question. You know what I love about sort of how it's happening now, how trials are going now, is that I'm glad you brought up cervix cancer, 2 new therapies, right? So cemiplimab showing a survival advantage over chemotherapy in the 2nd and 3rd line, and tisotumab vedotin showing response rate 24% with an 8-9 month duration of response now in phase 3 through the GOG. 2 major advances in cervical cancer treatment just in this last 6 months. And, neither commercially available yet, but these trials are making this happen. This is going to happen under accelerated mechanisms and priority reviews. And these are going to be available to patients faster because we did these trials through our partners and the way that we did the studies and with our European colleagues, which is really interesting.
And we're grateful to the women who agreed to participate, right?
Oh my
because
gosh.
without them,
how can we forget? No,
right,
they're really
we
driving
never
this
forget.
ship.
We never
They're
forget.
really driving this ship. We never forget.
Yeah. Without them, we wouldn't know as much as we know. So yes, of course, for them too. Yeah, but you're right. We've made tremendous advances in cervix cancer. We have things to offer people now that we didn't have to offer them before. And that feels good for them and for us both.
What I really love about our trials now is that instead of waiting until patients are out of options, like we're really very quickly, much more quickly than we ever have in the past, moving these new therapies up to earlier lines of treatment where hopefully they'll work better. I think, immunotherapy for cervical cancer specifically, trying to get that in the earliest lines of therapy with, your trial GOG 3047 and the BCC trial, just trying to get that in as early as possible. Hopefully it'll work better. I don't know.
Yeah,
I think that's why we're doing the trial.
What you said about international trials, because the GOG Foundation's participation has allowed us easy access to international trials that we might not have had access to before. And I think you and I have learned some differences between Europe and the US as an example, particularly in cervix cancer, but it makes the results of what we're finding more generalizable, which is really useful. And being part of a big international study like this is really a great opportunity that we wouldn't have without the GOG Foundation putting those relationships together for us. So that's been really, really helpful.
Yeah, that's such a great point. We're really learning about these differences. So the first difference that really came to light early was the screen fail discordance in cervical cancer trials. So our screen fail rate for cervix trials in the US is around 30%, a little higher in some of the studies. And in Europe is around 15%. So we're looking into that. Like I think there's some inherent differences in those populations. It's really, and we're America, so we always think we're better. But something's going on there, something's going on where we're behind our European colleagues in that regard, and we need to understand it and address it.
I wouldn't say we're better, we're different. Things happen differently here than they do in Europe in many aspects, particularly in access to care, right? So yeah.
No, I think what we sometimes assume that we're better, but we're not always correct in that assumption. So, well, it has been so great to have you today. Thanks. For brainstorming with us and just kind of talking through how you've approached your program, which has become really successful. I hope this can really help some of the investigators out there who are either starting a new program or you're trying to take your established program up to the next level. Dr. Deska has been through both of those phases and done so very successfully. So
with the help and support of many people. I'm so happy to talk to you about this today, but I have to give credit to my entire team for this program being successful.
Yeah, and I know your team and I can vouch for how amazing they are. They're really, really wonderful, but it takes a great leader too. And so I don't want you to discount the impact of your leadership. And I mean, it really makes a difference. And I know that, you know, I appreciate you and we
Okay,
appreciate you. Great. Thanks so much.
thanks.